to Wellness by Designs. I'm your host, Andrew Whitfield Cook. And joining us today is Gina Robertson, a naturopath, registered nurse, and former heart failure specialist nurse. Today, we're going to be speaking about the importance of magnesium in cardiovascular disease. Welcome, Gina. How are you? And thanks so much for your time.
Thank you for having me. Really appreciate this opportunity.
Oh, Gina, it's our pleasure. Firstly, can I ask, you, like myself, you're a registered nurse. I can still remember me being bashed over the head saying that natural medicine didn't work and was all a load of bunkum and that sort of thing. What piqued your interest in natural medicines to begin with?
I think this dates back to 2001 when I did the ACNEM course, Australasian College of Nutritional Environmental Medicine, and that was
Yeah.
their primary course. And of course, there was a lot about magnesium. So that always really stayed with me, particularly in the context of heart failure, chronic diseases, hypertension, and arrhythmias. And so that's been a real long-term interest.
But what piqued your interest to do the ACNEM course? I mean,
I think I already had a leaning, and I was doing a lot of research into natural medicines, bioidentical hormones, a whole lot of things really grabbed my interest, and
yeah,
that's kind of when it all started.
gotcha. And tell us a little bit about your history as a registered nurse working in cardiac wards and intensive care.
So most of my career was spent in intensive care. So that was both general and cardiothoracic intensive care with a little bit of peds in there as well.
Mm.
And I gave that away probably when I was, I'd been in that for a long time. And um, I was starting to struggle with the shift work. So that kind of dates back. From there, I went on and did pathology, hospital in the home, and that was where I got my entree into the world of heart failure. And
Yeah.
from there, I ended up moving back to Sydney and got a job there doing heart failure in a major Sydney hospital.
Right. A very famous Sydney hospital, I might add.
Yeah.
So you were working in the wards there. What sort of things did you see? We were talking off air just before, and you surprised me in that at least one of the specialists there started to use IV magnesium for certain indications.
Yeah, this was really interesting, Andrew. This was in a post-op neurosurgical intensive care, and the neurosurgeon used to run intravenous magnesium at extremely high, much higher than normal infusion rates. And his aim was to push the serum magnesium, and we know that serum magnesium is pretty useless for assessing
Hmm.
magnesium generally. But he used to push the serum magnesium up to about 2.0 and above, even higher than that, in order to address the vasospasm for patients that had had clipping of subarachnoid hemorrhage aneurysms or
Yeah,
aneurysms.
yeah. So just for people who aren't au fait with this sort of language, the clipping is to stop the aneurysm, the berry aneurysm or something like that, correct?
Yes. Yeah.
Yeah.
Interestingly, I was at a later stage working in a Melbourne intensive care. I had a while living down there, and I had a patient that went into SVT, otherwise known as supraventricular tachycardia, with a classic rate of about 180. And he had a history of ischemic heart disease. And I ran to get the intensivist after I flicked him across to a 12-lead ECG on his monitor. and his ST segments had dropped drastically, meaning he was starting to show signs of ischemia at that rapid heart rate, unsurprisingly. The intensivist came up to the patient, drew up a whole ampule of magnesium sulfate, and literally slammed it in.
Pushed it.
And I went, thinking he was going to drop his blood pressure drastically. But in fact, within about 10, 15 seconds, he reverted into sinus.
Wow.
And I was absolutely amazed. And it kind of occurred to me that what had happened there was with him slamming magnesium in as a bolus dose, which you never do. It's
No.
too vasoactive to do that. This was magnesium sulfate. He got a peak serum level enough to revert him out of that SVT back into sinus. It
Into
was
sinus. Wow.
quite astonishing to watch that.
Well, that's experience for you. That's really interesting, isn't
Yeah.
it? And
Interestingly,
yet,
while we're talking about arrhythmias, the post-operative heart bypass, whether that was bypass grafts or valve repairs, used to come
yeah,
out from theatre with magnesium loaded into their maintenance IV, their fluid. And the idea with that was to reduce the risk of post-operative atrial fibrillation, which is a common side effect post-operatively. So that was
yeah.
interesting, and
This gels with the work of Professor Frank Rosenfeld down at the Alfred in Victoria years ago
yeah,
now. And
yeah,
he preferred magnesium orotate, and it was actually the
yes,
orotic acid he was after. But magnesium on its own has this vasodilatory effect and helps with normal sinus rhythm as well. But very interestingly, the work like that he did, it was reducing atrial fib by 50%, reducing hospital stays by 30%, reducing the cost to patient of $2,300. And so the hospital went, as you were. We like this. Hospital saving, yes. Don't worry about the patient saving, hospital saving. But I thought it was very interesting, those improvements in patient outcomes.
very
So
groundbreaking study, that one.
yeah, so let's sort of go into magnesium and its role in the cardiovascular system. Can you take us through the major points here?
I think magnesium is the first thing that comes to mind when dealing with any patient with hypertension. And I think the best way for me to explain this is, Andrew, if I gave you a balloon, you would just take a big breath and blow it up. No issues at all. However, if I gave you a hot water bottle and asked you to blow it up, you would bust a gut trying to distend the hot water bottle. And that kind of equates to what's happening to the heart, trying to expel its output into the systemic circulation. And if that circulation is stiff and non-compliant, or left ventricular afterload, then the heart is really going to struggle to do its job, which is to pump and deliver oxygenated blood out to the tissues. So magnesium is the missing link here to help with turning that hot water bottle into a balloon, as it were. In other words, a stiff, non-compliant circulation, trying to help that to relax, as in the account of vasospasm we talked about before in
Yeah.
intensive care post-op neurosurge patients.
So that afterload is basically back pressure from a non-elastic arterial system, correct?
Yes, exactly.
Yeah.
So
Yeah.
magnesium is
And
the first thing that comes to mind.
It's what's interesting to me is that when you look at dietary guidelines, even cardiovascular stuff, they'll always mention potassium first and never magnesium. Why? I don't get it.
I think it's a lack of understanding about the level to which magnesium is involved with over 600 different enzyme systems and its relationship to the ATP pump, um, calcium, and so forth. And there's just a lack of recognition there. For
Mm.
example, I had a heart failure patient who, this is going back at probably about 9 years or so. She was really struggling, and I recommended a really good quality magnesium supplement for her, and only to be reported by the cardiac rehab nurse, who put in actually a complaint by saying that, why is Gina recommending magnesium because her blood levels are normal? And I just
Yeah.
shook my head and said, well, that is completely irrelevant, since the vast majority of magnesium is actually intracellular. It's not within the vascular space or the serum space at all.
This smacks of true ignorance of physiology, and there are certain um, elements, electrolytes, cations, anions, which just don't measure well in as a serum level. Chromium, zinc. There's so many, and yet, do you think this might be the issue about why it's these nutrients, let's say, are dismissed? Because if we can't measure them, it's not easy. We can't send them to the pathology lab. So what's the point? And yet, you'll get every now and
I
again,
think
you'll
it's
get a surgeon like every now and again, you'll get a surgeon like those that you've mentioned who know their physiology, and they know what this important electrolyte can do in acute, emergent situations. So
yeah.
it's really funny how people don't know about it.
Yeah, it's really important, and it's magnesium deficiency, whether it's significant or relative, is a huge and a widespread issue, particularly since people are dealing with a massive amount of stress, which is going to increase their need for magnesium, not less. So, in
Yes.
fact, they would need more magnesium. And I think for us as practitioners, we need to take on board the vast and different roles that magnesium plays. For example, I had a child in emergency one time who had severe bronchospasm, refractory to all of the normal things that they do with Ventolin and bronchodilators in general. And there must have been a very astute emergency physician at the time who organised for that child to have some intravenous magnesium, and that
Mm,
just
mhm.
resolved the bronchospasm. So it's
Yeah.
far, far broader than we, even as naturopaths, have understood.
That was one of the only sort of indications for magnesium sulfate in the old days was status asthmaticus. Not even any cardiac issues. It was only status asthmaticus, and I think maybe preeclampsia. And that's it.
Preeclampsia.
It was never,
Yep.
yeah, it was never ever used. Yeah. So back to cardiovascular disease. Let's talk about magnesium and what sort of conditions can magnesium help. And then I think we'll delve into what forms of magnesium, what doses, and what else you use with it. So, firstly, what sort of conditions do you tend to favour? Does it tend to be useful in?
Yeah. Number one, hypertension. And I think without access to adequate testing, we should assume that people are deficient and are going to benefit. So, for example, you might choose a magnesium supplement once, even twice a day. Secondly, for arrhythmias, this is incredibly important because we are seeing an increase in particularly AF now.
Yeah.
SVT, and other cardiac arrhythmias. And magnesium has a powerful role with helping to stabilize the electrical activity in the heart. So that's one of the first things that I would be thinking along those lines.
So when you're mentioning AF, atrial fibrillation, and we've spoken about supraventricular tachycardia before, SVT, when we're talking about atrial fib, um, the standard sort of progression is you'll get paroxysmal atrial fib, then you'll have all the time atrial fib or episodes, which may have to be treated by cardioversion. And what normally happens is the patient then goes on blood thinners, your flecainide sort of thing, and then they'll look at perhaps cardiac ablation in the atrial, the what is it, sinoatrial nodes or the atrium, and then possibly a pacemaker down the track. When you're talking
Potentially,
about, yeah, sorry, you go.
potentially, if people are cardioverted, which is a fairly standard practice, and
Yeah.
they're not preloaded, and continue their magnesium post procedure, they are very
Mm,
likely to revert back into atrial fibrillation, which is really
right.
disappointing.
Right. So forgive me. So they continue their magnesium after cardioversion and it doesn't work. It doesn't hold them enough.
It may not, because there's some irritation around those electrical pathways in the heart, and
Yeah, the
it
nodes.
is
Yeah.
common to revert back after being cardioverted back into atrial fibrillation. But I think magnesium pre and post would have a really, really important role there.
Right. Gotcha. And do you ever combine it with looking for like heart muscle damage markers, troponin I, or is it more to do with intracellular issues like nerve transmission, if you like?
I'd be probably more likely to try and get a copy of an echocardiogram report, because
Yeah.
that's
Okay.
going to tell a lot about whether the heart is struggling, whether there's dyssynchrony, all of those sorts of issues within the heart. But certainly there are lots of specialists, even at the hospital I worked in Sydney, that specialised in electrical anomalies within the heart, and that was kind of what they did. But for any ablation, any patient that has an ablation procedure coming up, the risk is that they can wipe out key electrical pathways, and the patient will end up with
Yeah.
a pacemaker or a
Yeah.
defibrillator, which is a combined device.
Right. Forgive me for asking because I'm asking for me here. Is this when we're talking about that the central bundle that runs down the intraventricular space that you can
Yes,
damage
and
that? Is that what it is?
higher up into
Right.
the atrium. So before they do an ablation, they have to do really complex and detailed electrical mapping of the
Yeah.
heart to try and identify where is the locus of abnormal activity.
Yeah.
So
Great.
this is something that we need to immediately be reaching for if we have patients with any arrhythmias, and go in hard.
Yeah. Gotcha. So forms of magnesium. You and I have spoken about the work of Professor Frank Rosenfeld with magnesium orotate, but we've had magnesium aspartate. I spoke with Dr. Ross Walker, who uses magnesium orotate aspartate, but we've got so many others that are involved in, or the ligands are involved in either helping to transport that electrolyte or have other functions with, say, nerves, for instance. So, so when do you sort of choose different forms, or do you tend to go, no, we'll always go with this?
I often and I always have prescribed a glycinated form because I think
Mhm.
that's generally reasonably bioavailable and fairly well tolerated. But I think there's a lot of evidence now for, I also recommend citrate for some patients as well. I think there's emerging evidence now for the use of threonate for neurological
Mm.
conditions. And I think Andrew, we will see an increase in threonate prescriptions
Oh, for sure.
now, because there's
Yeah.
so many people now suffering from neurological issues as well. The orotate, I think there is evidence for that as well. I tend to kind of fall back to um, prescribing patterns, just using something that I know works well and can trust.
What about using glycerophosphate, like as a phosphate shuttle?
Yeah, I think there's going to be um, glycerophosphate forms we will see more of now. And that may show enhanced bioavailability and effectiveness as well. So I think we will now see more of the supplement companies formulating in that form of magnesium as well. So
Yeah.
I think that will
Yeah.
become more common now.
Yeah. And then, we've also got accessory nutrients, taurine, zinc, fish oil, um, other things though, of use. What else have you used to help, other cardiac conditions?
Predominantly magnesium. And for example, I had a patient that recently had a quadruple bypass, and
Yep.
trying to get him to understand the importance of magnesium. And he's still actually not back on his magnesium um, as of now, 3 weeks post-operatively. But I don't want him going into atrial fibrillation. And it is important to support the energetics of the heart as well.
One of the things that interests me, it piqued my interest, and that was I've got a couple of friends who have got atrial fib, and one's got a pacemaker, um, but the use of quercetin. And there seems to be some evidence here with atrial fib. Have you ever used it?
I do often use it, and often use it as a zinc ionophore as well. Um,
Aha.
so that's also been very useful. I think a lot of people during COVID actually got the CD zinc message, and
Yep.
it was, I forget his name, he's passed on now, but he brought to the public's attention about how quercetin is acting as a zinc ionophore to get
Right.
the zinc intracellular, or to enhance intracellular transport of zinc.
Right. Now, forgive me, was this the guy that put a private message to his friends on Facebook and it got out, and he was a virologist? Was it that guy or somebody else?
No, it was the
No.
name will come to me later, but it
Yeah,
was,
yeah.
he actually treated, President Trump was, in office at that time, and he treated him as well when he got COVID. So, he certainly used all of these C, D, and zinc, with
Yep.
quercetin as an ionophore. So
Gotcha.
potentially it has other roles with other minerals as well.
Gotcha. Okay. And what other sort of nutrients, what other herbs, in fact, do you use with cardiac conditions, and where? I remember I keep defaulting and under, I don't think this is right, but it was a trial on hawthorn leaves. And I keep going DART trial. It wasn't called the DART trial. That was diet and reinfarction. Um, there was a trial that was done on hawthorn, but quite some years ago. Do you ever use herbs, and for what?
Yes, and I do use that with heart failure. It's particularly useful with heart failure classifications. There's 1, 2, 3, and 4. 4
Yeah,
is I cannot get out of the chair or bed, I'm so breathless, even at rest. 3 is breathless on very minimal exertion. 2 is where most people with heart failure sit. They're breathless with exertion, such as going upstairs or an incline. And 1 is they have heart failure, but they have no symptoms. So there is good evidence to use hawthorn in class 2 and 3.
right.
So sometimes I might even use that as a standalone. For example, I've got a patient locally with myocarditis and post jab, and she is using the hawthorn as well, amongst many other supplements.
The other thing, of course, the other nutrient I guess we should talk about is ubiquinol. How often do you use it, and do you tend to favour certain conditions? Do you ever use it judiciously? How high do you go?
Yes, I use 300 milligrams a day of ubiquinol, not ubiquinone, because for most people, once they're over 40, they're going to do better on ubiquinol. So I do use that. In fact, I recommended it for a patient with heart failure I saw yesterday. Uh, and it is all, again, about supporting mitochondrial energy production. So, of course, we're thinking magnesium, we're thinking B vitamins, we're thinking CoQ10, in this case, ubiquinol. So that is something that I definitely would recommend often. The other thing, Andrew, that comes to mind is for so many patients are on proton pump inhibitors now, and
Yeah.
obviously we know that if you change stomach acid, you're going to impede the absorption of magnesium, zinc, folate, iron, B12, calcium, and so on. So for those people, there are some that we're never going to get off PPIs, potentially. Those with Barrett's esophagus, possibly. Those with a
Mm.
hiatus hernia. So I'm kind of leaning more now to trying to bypass that absorption altogether and putting those people on a topical magnesium as well. So just using a really good quality magnesium spray.
Right. And clinical effects?
Clinical effects are seen more rapidly, probably in kids.
Right.
So
Of
for kids with anxiety, really difficult to get to sleep, all of those sorts of things. And often the topical magnesiums are a magnesium chloride, but it seems to get fairly good absorption, and you notice the effects more readily in those people. I've got one patient who is using topical magnesium he's got a diabetes related peripheral neuropathy. His feet are affected. So he's using that both feet, and he's getting really good results with that.
Okay. And what
So
about
I think the
dose?
idea here is to get as much magnesium into the system as people can cope with.
Great. Okay, so that leads on to my next question. That is doses. Like we've got to obviously circumvent bowel tolerance, which I've had a wide breadth of experience here with different patients. Somebody who could tolerate NAFL, and we had to use a really poorly absorbed lower dose magnesium, and other people that can really, really take a lot of magnesium in and without any effect on their stomach, on their intestines whatsoever. What's your experience? What does it show you? What is there a sweet spot with dosage with magnesium?
I think, as you said, it's very individual. Some people will not even tolerate, like they might get diarrhea with a sort of a half decent dose of magnesium glycinate. which to me is a very well tolerated
Mm.
bioavailable form of magnesium, other people can soak it up like a sponge.
Yeah. Yeah, it's really amazing. I'll always remember this, the triathlete from Kilcoy. You know how you remember patients because of some aspect of them? The triathlete from Kilcoy, and he just could not tolerate magnesium. And in the end, we had to use a pretty poorly absorbed phosphate type, lower dose thing. And he wasn't really getting great effect, but it was like all that he could handle with bowel tolerance. And that's when I spoke to him about perhaps find an integrative GP to do intravenous magnesium. Eventually, I lost contact with him. The other side of the spectrum is I'll always remember this. I did my neck, drying my hair with a towel. I mean, these anecdotes. But I took 3 teaspoons 3 times a day. So a total of 9 teaspoons. Like that's 2, 4, 6, 3, 6, 1,800 milligrams. Massive. And um, no bowel tolerance whatsoever. And I'll always remember a few months later, I related it to somebody who walked in to where I was practicing like this with tears in her eyes. I said, "What have you done?" Put my neck out. I said, "Okay." Got her booked into somebody that was going to look after her treatment later on. But for now, I said, "Okay, let's get you onto some magnesium." And I said, "Now I've taken 3, 3, and 3, total of 9 teaspoons, right?" And 2 weeks later, she and I said, "Look, I don't normally do that. I normally go 2 and 2 for a high dose, and as long as their renal function's okay." But a couple of weeks later, she came back and she said, "I tried that 9 teaspoons, like you said, but gee, it cleaned me out." And I said, "Well, how did you take it? Like 3, 3, and 3?" She said, "No, no, 9 teaspoons." Stat. I said, "How did you stir it?" But to me, it's pointing. She said it worked really well, but it cleaned me out. I just thought, oh, yeah, that it's a lesson in explaining instructions clearly to patients, I think.
It is really important to be really specific with dosing. That one guy that I mentioned that's recently had a quadruple bypass, he
Yeah,
overdosed on his magnesium and had the same thing. He didn't follow my explicit instructions, and he was yeah, he had diarrhea. So it is
yeah,
something, no matter how explicit I copy their prescription into their plan so that they know exactly what they should be doing. And some people just maybe they don't follow instructions well
mm,
and they can
yeah,
overdo it. And the other thing of concern is too, if people obviously, when I was a heart failure nurse, I had a lot of patients with very, very reduced renal function. And once you get
yeah,
to an EGFR of less than 30, you've really, really got to be cautious, as with any medicines
mm,
and supplements. Some supplements, not all, but magnesium is one of them where you really need to back off on that dosing because you don't want to cause them any issues, because obviously magnesium levels are controlled by the kidneys to
yeah.
some
What
extent.
was your level of cutoff? What was your level of woo back off? 40,
EGFR of 30 or less.
30 or less?
So
Gotcha.
often as naturopaths, we're panicking about slightly reduced EGFR, but for many patients, it's not really an issue, and they can tolerate most meds and most supplements until their renal function is really markedly reduced.
Yeah, yeah.
So
And it
I'd,
makes
I'd want to become cautious at that level.
just a last question, Gina. How can we encourage patients, and what can we recommend with regards to lifestyle factors to help with their cardiovascular health?
I think all the things that we do well as naturopaths, which is transitioning people to a whole foods diet, rich in vegetables, particularly the dark green and leafy nuts and seeds, really good quality protein, moving away from sugar,
Mm,
which is going to deplete people's magnesium, chromium, and. So,
mm,
stress management is always going to be a big part of what we look at as naturopaths. And for example, exercise, being outside in nature, grounding, all the things that we want to encourage people to do to manage their stress. But I can say that stress is rampant right now, and that's something as naturopaths I think that we do really well. And whilst magnesium, zinc, all of those B vitamins are going to help with a stress response, we still need to come in with dietary modifications and all of those lifestyle things, stress management. You know, for some people, it will be meditation, for other people, exercise, grounding, all of those sorts of things that we normally would do in a consult.
Gina, there's obviously a wealth of expertise there through, and I'm going to say it without fear, but many, many years of practice. So, thank you so much for taking us through not just magnesium, but everything else that we can use to help our patients with cardiovascular issues. Thank you so much for taking us through these today, Gina.
Yeah, you're very welcome.
And thank you, everyone, for joining us. Remember, you can catch up on today's show notes and the other podcasts on the Designs for Health website. I'm Andrew Whitfield Cook. This is Wellness by Designs.